Good afternoon. My name is Patrick Cooney, and I'm the president of the Federal Group, a government relations firm based in Washington. And pleased on behalf of our client, Redsense Medical, medical device manufacturer catering to the needs of kidney patients undergoing dialysis, to bring you this briefing today, along with our other co-hosts, the American Association of Kidney Patients, the American Nephrology Nurses Association, and the American Society of Nephrology. Today, it's estimated that there are 37 million Americans in the United States that have chronic kidney disease, also known as CDK. And for nearly 800,000 adults in the United States, kidney diseases progress to kidney failure, also known as end-stage renal disease. You might refer to it as ESRD, a life-threatening condition which requires management by a kidney transplant or dialysis. So today, we wanted to take just 30 minutes out of your day to bring to you 4 experts in this area who will talk about the impact on patients and also the role of health professionals in sort of mitigating the risk of venous needle dislodgement, and share with you their experiences in the field. First, I want to introduce Paul Conway, who serves as the chair of policy and global affairs for the American Association of Kidney Patients, America's largest kidney patient organization. He is a 40-year kidney patient who spent 3 years on dialysis and has had a transplant for the past 25 years. He is the former chief of staff of the U.S. Civil Service and has a background in federal and state health programs, medical innovation, and reimbursement issues. Debbie Brower-Mayer is a nephrology nurse with 39 years of experience. Her focus is on the care of hemodialysis vascular access, and she's the author of multiple publications on this topic. She served as the working group member for the 1997, 2000, 2006 NKF kidney disease, KDOQI vascular access guideline work groups, and is the current co-chair of the 2019 implementation work group. In addition, she was one of the authors of the American Nephrology Nurses Association's Venous Needle Dislodgement and Access Bloodline Separation publication and toolkit. Our third speaker, Dr. Ankur Shah, is assistant professor of medicine, clinical educator at the Warren Albert Medical School at Brown University. He is a practicing nephrologist in the Division of Kidney Disease and Hypertension, of where he's an associate program director of the nephrology training program and medical director for the home hemodialysis program at DaVita North Providence. He is a fellow of the American Society of Nephrology, the National Kidney Foundation, and the American College of Physicians. Last but not least, Jane Hurst is the U.S. Clinical Director for Redsense Medical. She has more than 40 years of experience as a registered nurse in a variety of specialty areas in education. She's also a certified legal nurse consultant with an expertise in medical legal issues. Jane has worked with Redsense Medical since 2007, when the Redsense alarm was first introduced in the United States. Thank you for joining us today. We know it's a busy time up on Capitol Hill, but thanks for sharing a bit of your day. And I'll pass it off to Paul Conway to begin his presentation.
Thank you very much for the introduction, Patrick. My name is Paul Conway, and it's a pleasure to be here today. And I'd like to especially thank Patrick, as well as the members of the Bipartisan Kidney Caucus on Capitol Hill. The past 10 years have been a very optimistic time for patients as we've gotten greater choice in our care treatments, and the ability to use innovations and technologies that are out there to make certain that we have a lot of different opportunities to manage our kidney disease. One of those opportunities and one of those changes is greater access to home hemodialysis, especially for patients all across America who are trying to figure out how to maintain a full-time or part-time job, or how to return home and have a little bit more flexibility in life. There have been great policy changes that have enabled that, and great technologies that have come online through the FDA that allow patients to do dialysis at home, now sometimes with family or without a family member. But the issue that we're talking about today is very important. It's about the dislodgement of needles that connect you to a life-saving treatment and machine that circulates the blood in your body. I know this quite well. I did dialysis for a very long time. But the key thing that's here now is the issue of what concerns patients the most when they're trying to make that decision to go home. So there are a lot of different factors that patients have to sort out, whether or not they want a lot of supplies at home, what the burden is on family members, whether they'll be able to do their treatments on time. But one of the things that's underlying with most patients is what happens in the event of a negative circumstance. For example, if a needle becomes loose and you bleed out. The good news is there's technology that can alert patients to this and caregivers. But what we're trying to do is make certain that the same technologies that exist in the dialysis center can also exist at home, so that risk can be mitigated and managed by patients or family members or caregivers, so that that confidence in being able to go home and have your treatments and have a greater sense of independence can be there, and not just for the most motivated patients, but for a wider group of patients. And so as we take a look at this issue today and you listen, think to yourself how you would feel if you had a technology that might be accessible to you that would give you greater confidence, because that's exactly what we're going to talk about here, and why it's so important in an era now when there's been a great change in policy and where there's a great emphasis on trying to get patients to go home and take advantage of that new opportunity that exists through technology and through policy. Right now, I'll go ahead and throw it over to my colleague, Debbie, and she can walk through the details of what happens during the dialysis process and what happens if a needle becomes loose. Thank you. Debbie, go right ahead.
Hi, thank you so much, Paul. So if we could start the slides to share with everybody. So as I said, I'm a dialysis nurse, and I was part of the group that put together a toolkit and an article with the ANA nurses to look at how we can prevent this issue. Typically, it's called venous needle dislodgement because we think of the venous needle coming out, but there's actually also a risk of the access bloodline separating. There is a connection either by a catheter or needles that go into the patient. And if you can turn to the next slide, please. This is just very quickly a picture of what the outpatient typical dialysis facilities look like and a dialysis machine. The patient there is connected with needles to the dialysis machine. So we have an access to pull the blood out, put it through the artificial kidney, clean the blood, remove the fluid, and then put that clean blood back into the patient. Next slide, please. So there's two types of vascular accesses, and that's why when the ANA task force redid the current, there was a previous work, we added the issue of the catheter disconnect because it's a risk of either the needles coming out or the bloodline separating from the catheter, or even the bloodline separating from the needle connection itself. And there's different risks associated, but in essence, it's the bleeding that's the main concern. Next slide, please. So I'm going to skip this because our physician is going to talk about this. So if we go to the next slide. So basically what I want to talk about is the nurse's perception of this. The venous needle dislodgement or the access bloodline separation can occur anytime a patient is dialyzing. And we think about what Paul said there about the concern for patients at home. This is not something that happens once a month. Patients dialyze 3 times a week, 52 weeks out of a year, or 156 sessions a year. And there's an arterial and venous either needle or connection with each one of those treatments. So when we look at risk mitigation, and that's what in the healthcare field, we always try to mitigate any risk, we're really looking at the possibility of 312 events that could happen a year for a single patient, whether they're in center or at home. That's a really high risk, and that's why this is such a concern to try to mitigate. Next slide, please. So the current mitigation, I just want to explain that we do try to look for the needle falling out or the blood lines disconnecting. But what can happen, and I unfortunately witnessed this very many years ago when I was a new nurse. We had a patient where the catheter disconnected from the line and the catheter went down into the chair, and the dialysis machines use pressure to try to mitigate any of these risks. And what can happen is the access point can fall against the blanket, the patient. It doesn't change the pressure enough to trigger the alarm, and hence the event can occur. So these are the tools that the ANA group came up. We have a patient tool, we have a staff tool, and really the current mitigation is visual inspection, trying to make sure that that hasn't come apart, because the dialysis machines are not always going to pick up the actual pressure change that happens on the venous side. The arterial side, they tend to alarm when enough air has been pulled into the system and we have an air detector, but on the venous side, that doesn't happen. And at this point, I'm going to turn over to the physician. He can explain to you why it's such an issue with the blood volume.
Thank you. If we could go back to slide 4. Thank you. First of all, thank you for having me, and thank you for taking your time to learn about venous needle dislodgement. So I'd like to use a few minutes to just explain what it is we're talking about here. And first, before I go into this slide, I just want to talk a little bit about and emphasize the reality of dialysis. So dialysis is a life-sustaining therapy, and for those who need it, life would only last weeks without it. It's life support. And dialysis filters your blood just as your kidneys would do if you drink a liter of water, as I have here. Without that liter of urine, you would retain that water and develop swelling. If you eat a steak, you need to process the protein, the urea, the potassium, the phosphorus. Your kidneys do that. And when your kidneys are unable to do that, we use dialysis, which is basically a filter to do it. But the problem is your kidneys have 168 hours a week to work with. And with dialysis, I only have 12. So I've got to work fast. And so when I say we work fast, you have about 5 liters of blood in your body. I clean that at a half a liter a minute. So we dialyze your entire blood volume every 10 minutes, and we keep cleaning your blood volume. But to do that, we need to remove 10% of the blood in your body every minute. And we remove it, we filter it, and we return it to your body, except for if that venous needle is dislodged. If your venous needle is dislodged, that 500 mLs per minute is how fast you're losing blood. So in 2 minutes, you're in shock. In 10 minutes, you've died of exsanguination. This is kind of the widowmaker heart attack of dialysis. It's our most feared complication. And it's something that I've seen. It's not an abstract problem. When you see this, it is gruesome. This is not a solution in search of a problem. It's really a problem in search of a solution. And just to give an example of how much of a problem it is, from 2000 to 2006, this was the cause of death for 1,600 Americans, and 80% of those events occurred at home. And the actual machinery that we have is no better today than it was then in sensing, detecting, preventing this. There's a lot of reasons this can happen: improper needle taping, suboptimal cannulation technique, not securing the blood lines appropriately, moving. Other factors could include covering the needles and the blood lines with blankets or changing the pressure alarms. And so there's a lot of things that we do to prevent this. And in spite of all of those things, we still have this as a major problem. So as you saw from our last speaker, we do things like using consistent procedures for the needle and bloodline, keeping the access and bloodline connections visible at all times, regular monitoring. We prohibit staff from adjusting alarm limits. We educate staff and patients about VND and its consequences, but this still happens. And there are certain groups who this is a higher risk for. And those groups include people who are restless, people with dementia or altered mental status who can't tell you if they're exsanguinating, people who have a difficult access or allergies to tape, and then one group that I want to focus on, which is those who do solo or nocturnal home hemodialysis. If this happens to you at home, you have 2 minutes until you're in shock. You have 10 minutes until you're dead. So even if you can call 911 in that 2 minutes that you have, 911 isn't going to get there in time. So I'm here as a proponent of home dialysis. That's why I'm here. And the home dialysis has become a governmental priority. And as I'm leading efforts to build our home programs, I talk to patients that, yes, home dialysis gives you more flexibility, but it comes with more risks. And while federal policy is interested in increasing home dialysis utilization, and this has been a bipartisan interest, we need help to make sure that this modality is safe at home and that we can provide just as good care for our patients as home as they would get in the center. So that was kind of my overview. I'll hand it over to Jane now. Thank you.
As my colleagues have indicated, venous needle dislodgement is a serious and potentially life-threatening complication, and prevention requires a collaborative effort. Venous needle dislodgement is very, very unpredictable, and it can happen to anyone at any time in the blink of an eye. I'm going to show you a short video of a controlled venous needle dislodgement that was done in the clinical setting. I do not think it's extremely graphic. However, if you're squeamish about the sight of blood, you probably would want to turn your head. I want to explain that the dialysis machine in this particular demonstration is running at a much slower rate than what is typically done for a treatment. So the blood is not coming out of the needle as fast as if it would be running at full steam. What you will see is that as soon as the needle is removed, blood begins pouring out. It's pumped out all over, and an older version of the Redsense alarm, which is a blood loss detection device, will begin to alarm as soon as the blood begins escaping. So Patrick, if you would go ahead and please show that, I'd appreciate it. So they're preparing to pull the needle. As soon as the needle is pulled, the blood, instead of returning to the patient, is being pumped out into the environment. Okay, so it happens very, very quickly, and the machine just continues to pump blood. It doesn't realize that the patient is no longer connected to the end of the needle. And the sheer volume of blood that is quickly pumped out cannot be understated. Like Debbie, years ago when I was a dialysis nurse, I witnessed an undetected venous needle dislodgement. And the best way I can describe it is it resembled a bloody crime scene. So the blood escapes very, very quickly, and there's little time to react. Visually monitoring the venous access is the most reliable method of preventing venous needle dislodgement. However, realistically, that is not always easy or possible, especially when you have patients identified at high risk. For example, a patient who's confused or restless in a clinic setting, it can be very difficult to provide the one-on-one monitoring due to the limitations in the staff, the number of staff. If a patient dialyzes overnight at a clinic while they sleep, the lights are dimmed. It makes it very difficult for the staff to be able to visualize the venous access. And of course, the patient is asleep. So the number of eyes on that access are severely diminished. Likewise, if a patient is dialyzing at home and they are sleeping while they are having their treatment, their access is not monitored. In fact, anytime patients do treatments at home, either with a care partner or solo by themselves, they are at increased risk of venous needle dislodgement. Home patients master all the technical aspects of the dialysis procedure, and they are also well educated on measures to take to prevent venous needle dislodgement. However, it still can happen. And as more and more patients move home to do dialysis, the risk also increases as the number of patients increases. So the role of Redsense in risk mitigation is to provide an added layer of protection and peace of mind with a device that continuously monitors the venous access, and it immediately alarms if blood is detected. That enables the staff, the caregiver, or the patient themselves to quickly turn off the dialysis machine to stop the blood from pumping and minimize the amount of blood that is lost. The Redsense alarm functions independently of the dialysis machine, so it relieves concerns that the pressure alarm may not detect a dislodgement. And it's like using a smoke alarm. You hope you never hear it, but there is peace of mind, security, knowing that there is monitoring. We thank you for the opportunity to have this conversation about venous needle dislodgement, because the more people who are aware, the better we can serve our dialysis patients. So Patrick, I'll hand it back over to you.
Thanks so much, Jane, and thanks to our other wonderful speakers today. We wanted to bring this briefing to you in a short, concise manner because we know how busy you are on Capitol Hill with the activities of the day. But we wanted to provide a few minutes if anyone has any questions. We'll certainly be sending this recorded briefing around to your colleagues up on Capitol Hill so that they can view it at a time that works for them. But if there are any questions, our panelists are happy to take them now. And just feel free to unmute and you can ask your question. Yeah, John, looks like you have a question.
Oh, thanks. Thanks, Patrick. Thanks to all. It was just a great presentation. I learned a lot. And I think you delivered it perfectly for the level of expertise of the audience. Most of us, I guess, are not doctors or nurses. So I was really grateful that you brought up demented patients. We're at the Senate. I'm at the Senate Aging Committee, so Alzheimer's and related dementias are a big deal for us. I can see a lot. This isn't directly well, it is directly, but the at home. When you're moving the demented patient to any kind of clinic, that there's a whole bunch of risks there, right? And so what are the special things that you do with a patient with Alzheimer's or related dementia to mitigate the risk you've described?
Patrick, this is Debbie. Do you want me to go ahead and start first
That'd
on
be
that
great.
one?
That'd be great.
So what we've done with the ANA tool is we actually have a risk stratification that the dialysis staff can use to help determine the patients that may have this higher risk. And dementia comes in a lot of forms. Some people are very clearly disoriented, and other people are in those earlier stages where they may drift in and out. So the form helps the dialysis staff to kind of look at these patients because unfortunately with dementia, you're not only dealing with the possibility of the needle coming out, but often the patients don't like the needle going in, or if they have a catheter, the catheter connections. So there's a lot of care that has to be given when you're dealing with a patient that does have some level of dementia, to either connect their dialysis treatment, try to figure out how to secure the needle or the catheter connections so the patient doesn't disconnect it during the treatment or pull it out, and monitor. And unfortunately, the monitoring without using the Redsense is the only currently FDA cleared device. It's the eyes of the staff or the care partners. And there is a lot of dialysis that's now being done at nursing homes as the residents of patients, and dementia patients certainly do better when you don't have to pull them out to a center and you can deliver it at their home location. And certainly using any kind of device that helps detect that is really helpful. And in the US, the only device currently is the Redsense device. And I hope that, John, that answered your question.
Yes, it does. Thank you. And again, thank you all of the presenters for a very educational 30 minutes. Thank you.
Patrick, can I add one quick thing to this?
Sure, Paul.
John, I just wanted to say thank you very much. Up on the Senate side and across the House, but in particular on the Senate Aging Committee, you folks have really leaned forward on issues of aging and on dementia. And what's been fundamentally important during the course of COVID is this, that people understand that all kidney patients should be treated with dignity and respect. And increasingly, families have understood that during this crisis, there are burdens on caregivers and care professionals who are in nursing centers and also in assisted living. And there's a need for people to feel like they have the confidence that if they want to bring a loved one home, that they can, even if that person has something like dementia, there's still a desire to bring that person home by many patients and many patient advocates, and for all good reasons. But what you're identifying here and seeing here is one of those tools that with an access to innovation could actually help empower patients and families so they could do better in their efforts to try to take care of somebody. It's tremendously difficult, but at the American Association of Kidney Patients and with the professionals that are on here, we don't feel like somebody should be denied a choice or a family denied a choice simply because of the lack of access to a piece of technology that could actually help them do their job better. And that's one of the key takeaways. But I wanted to say thank you for the work that you folks have done up there because you view all people as people with dignity. And this is a key issue that's related to that. Thank you.
Great. Well, thank you so much for joining us. Again, we will share this briefing with your colleagues in the coming days. Have a wonderful afternoon, and thanks for taking the time to learn a little bit more about venous needle dislodgement. And thanks so much to our speakers today.